It's my pleasure to introduce our next speaker, who again needs no introduction, Dr. Brian Halbert, who many of you know either from Ochsner or from CAGLA community. Dr. Halbert is a staff physician in the GU Oncology at Ochsner MD Anderson. There, he leads the Advanced Prostate Cancer Clinic and spends his days in the trenches, really managing complex prostate cancer cases, which we see a lot of here, and thinking about how we actually deliver modern treatments and the next generation of treatments to patients in the real world. He's been doing very thoughtful work in this space, including a project through the Alliance looking at home health monitoring for prostate cancer patients, and an American Cancer Society funded initiative focusing on expanding PSA screening and treatment access to the river parishes. So not just studying disparities, but actually trying to fix them. And as we all know, we happen to live in Cancer Alley in this area, so this is very relevant work. So please join me without further ado in welcoming Dr. Brian Halbert, who will be speaking on bridging the gap.
Thank you guys so much. I always enjoy coming to CAGLA every year. It's fantastic. Agreeing to speak after Dr. Sarter and Dr. Pillier, I'm not quite sure what I was thinking this year, but we'll make it work. It also occurs to me, I think we're going to be doing a roundtable afterwards, and I see one microphone, so I wonder if we can get that same handheld microphone that the general was using earlier. It's over there. Okay, good. Well, I'd really like to thank our previous speakers, really doing a great job of setting up some really cool things that we are doing in cancer clinics for what we can do for our patients, particularly with radioligand therapy, what we should be doing for them in regards to radiation therapy and androgen deprivation therapy. But I want to take the talk in a little bit different direction and not think so much about what we can do, but really start thinking about how we can do it, and how we can do it in a way that's going to deliver equitable results for all of our prostate cancer community. I do have some disclosures. I do some ad boards. I also have to disclose that I did use ChatGPT to come up with my title, but I do promise the rest of this is going to be me and my sources. A couple of objectives that we have here today. Sure, is this working? No? Okay. I can stay back here. We should just get this working for the roundtable. Put it there. All right, so a couple of objectives here today. First thing, I really want to make sure that we review the current state of disparities within prostate cancer. We know they're there. We see them, we feel them in clinic every single day. I want to think about what goes into implementing a radioligand program and what sort of barriers may exist as we try to ramp up these treatment strategies throughout the country. And then hopefully I'd like us to at least start to think, particularly the people here in this room and the people within CAGLA, what kind of ideas can we come up with to start to address some of these barriers as we start to use more and more radioligands. This slide is just basically to remind you of everything that Dr. Sarter was just saying. Radioligand therapy is here in prostate cancer. It is not going away. We are only going to see it more and more and more, not just in prostate cancer, but also throughout other cancer types, not just in post-docetaxel castrate-resistant disease, or we're going to be seeing it in earlier disease space. This is going to be more and more patients being treated with these drugs over the next several years. So we have to be very intentional with how we utilize or how we build out our programs so that we don't exacerbate current disparities that we see. This is really what got me thinking about this. And if there's one slide in this deck that's going to get me in trouble, it'll probably be this one. But I'm hopeful that if you guys follow my thinking on this, we won't necessarily come across this as being particularly controversial, okay? I don't know how many of you guys are familiar with the man over here on the left. That's Scott Adams. He became moderately famous decades ago as the creator of the Dilbert comic strip. It's a good strip. I remember reading it growing up. Really lampoons office culture in the country. Later in life, he also became moderately famous for being particularly outspoken on social media with certain, kind of conservative firebrand politics. Really was kind of plugged into the Twitter sphere of the political moment. During this timeline, though, he was also suffering from prostate cancer. And late last year, it was decided that he might benefit from Pluvicto, and he was trying to get access to the drug out in California. And I don't know what happened, but apparently he had some trouble getting access to it. And so he utilized his connections in the social media world, and he tweeted out directly to the President of the United States and to several top administrative officials saying, hey, I need some help here. I need help getting this drug. And, social media being what it is, he got response in, minutes. He got the Secretary of Health and Human Services saying, we're on it. We're going to get you this drug. We're good to go. At the same time, many of you might recognize this quote over here on the left. This is from the New Testament. It's from Matthew 25. And it's one of Jesus' most famous parables. And really what it is telling us is that, or at least for his disciples, we're not going to be judged necessarily by how we treat our friends and the most advantaged and the rich in this world. But when it really comes to our judgment, we are going to be judged by how we treat those who are the least advantaged. Okay? So I don't think it's particularly controversial to think about that, personally appealing to the President of the United States to get access to healthcare is not scalable. And it's not really indicative of a healthcare system that's functioning the way it should be. I also think that regardless of where you're coming from a moral or ethical or religious bent, that we should judge our healthcare system on not how it treats the most advantaged and the rich, but how it treats the least advantaged of all of us. And we know that prostate cancer is not, the burden of prostate cancer is not shared equally. This here is data looking at the incidence of prostate cancer diagnosis by race in the United States. And then on your right is the incidence of prostate cancer mortality in the United States. And if you look at it, I don't know where my pointer is here. Well, suffice it to say, if you have 100,000 men, 188 black men are going to be diagnosed with prostate cancer compared to 113 white men. But even more striking is within those 100,000 men, I can't quite read it, but it's like 36, I think, of those black men are going to die of prostate cancer compared to about 17 for white men. Black men are more than twice as likely to die of prostate cancer than white men in this country. And this led to one of the more provocative JCO editorials that I had seen in the last several years. This was published a couple of years ago, and it says, racism does not cause prostate cancer, but it causes prostate cancer death. And the point of the authors in this article wasn't necessarily be particularly controversial or provocative, but what they were really getting at was this gap in prostate cancer mortality cannot be entirely talked away by diagnosis and genetics and biology. But there truly is something baked into our healthcare system that is leading to unequal outcomes for our patients. Now, the root cause of healthcare disparities is clearly across the entire gamut of public health. That's more than I can talk on in a lifetime, right? And as physicians, we're typically focused kind of on the bottom part here of this here, the healthcare system. But if we really want to make sure that we're giving the best care to all of our patients, it would be folly of us to kind of turn a blind eye to these other sorts of issues that we have to think about. And if we're policymakers, or if we're talking to policymakers, we also have to make sure that they are addressing all these other sorts of issues that we're looking at. Economic stability, are we giving good jobs to our entire community? Food security, do we have access to good health and nutrition, particularly for the kids amongst us? Do we have good community and social support within our communities? The built environment, access to playgrounds and green space is very important for public health. And then education. We need to be providing high quality education so patients can have the health literacy to help take care of themselves. And then of course, healthcare systems, which is kind of what we're gonna be talking about a little bit here, therein. So where are we right now in prostate cancer disparities? Well, this looks at some of the disparities in prostate cancer diagnosis. So despite the fact that black men are diagnosed usually at an earlier age and more advanced stage, they are less likely to get PSA screening tests than white men. This is over here on the left with the percentage of white men having a PSA screening test in red and black men in blue. And then once you're going to go for your biopsy, what's the likelihood of receiving advanced imaging with MR targeted biopsies before getting your prostate biopsy? It's considered, we consider that to be a best practice. You can see over the years that has been going way up, but it's not equal between the races. In white, I don't think it says it there on the screen, is the percentage of white men getting an MR targeted biopsy versus black men. What about disparities in treatment? Well, we know that it's race is included. Black men are less likely to get definitive therapy for prostate cancer once they're diagnosed. But it also goes across not just race that we're looking at. It's also socioeconomic status. If you have lower socioeconomic status, you're less likely to get radiation therapy or radical prostatectomy. Geographic disparities are very real. People in rural settings are less likely to get guideline concordant high quality care than those of us in urban centers that have access to academic centers. Travel distance is a big issue for these patients. Insurance status. If you have a good, high quality private healthcare system or healthcare payer, you're much more likely to get definitive treatment, and patients on Medicaid are more likely to be diagnosed with more advanced disease. This is kind of an old slide looking at access to PSMA PET imaging. This was published back in 2023. So this was just simply like pointing a little on a map of where there's PSMA PET imaging that's available. I certainly hope this looks a lot different today, because I think Denver has probably gotten access to a machine by now. But still, it does show you how, whenever we roll out new technologies like this, they really do tend to be clustered within certain geographic areas, and we need to think about how can we not create more of these disparities. And finally, there's a very real element of distrust within the medical system from some of our in certain communities. I do a lot of kind of community events looking at screening awareness within the community and trying to get guys out there to get tested. Talk about enrollment in clinical trials is a big thing that we talk about. And one thing that always comes back to us whenever we do these events is people want to talk about the Tuskegee untreated syphilis study. So this is a picture there from US website showing that the United States Public Health Service from the 1930s to the 1970s conducted a longitudinal study in black men from Macon, Alabama, who were diagnosed with syphilis. And they did not tell them that they had syphilis. They did not tell them that they were in a research study. And they didn't tell them that there was treatment. And they didn't treat them. And that has left an indelible mark on the amount of trust that we have in the healthcare system for many patients. And that's real. Not only that, but the workforce of the physician workforce in this country does not adequately represent the communities that it treats. This country is about 14% black, but only 5% of the physician workforce is black. So we need to think about how we can make it more representative of who we are treating. As a result, you see things like black men are more likely to report distrust in the medical system, and they're more likely to report poor communication with their healthcare providers. But we know that if you put patients into an equal access environment, these disparities disappear. So it's not that certain men are just more they're just more likely to die of prostate cancer. No, if you give them an equal opportunity, people do just as well. And so if you look at this is a forest plot looking at the prostate cancer specific mortality. On the top is the SEER database, so that's just the real world data showing that black men are more likely to die of prostate cancer. But if you put them in the VA system, or if you put them in a randomized controlled clinical trial, we see that mortality discrepancy disappear. So that's where we are with discrepancies in the country today. But let's think about what we can do to implement radioligand programs so that we don't continue to worsen these sorts of disparities, and what goes into the development of a program. It's complex. I mean, I as a medical oncologist, coming out of fellowship several years ago, I was fairly naive in the ideas of what really goes into making a radioligand program. And so over the last couple of years, we've really had some experience in figuring out where those pain points are. So first of all, regulatory burden. I mean, if you think about it, we're infusing patients with radioactive material. I mean, I guess if anything needs to be carefully watched over, I guess that is one of those. But there are several overlapping bodies that regulate the radiopharmaceutical industry. There's obviously the FDA, who's responsible for approving new drugs, but the licensing and use of these radiopharmaceuticals is regulated by the U.S. Nuclear Regulatory Committee. And then there's other layers where certain states may have state bodies that are involved in the regulation. There are certain agreement states that have signed contracts with the U.S. federal government that says that they can regulate it. I believe Louisiana, we are regulated through the Louisiana Department of Environmental Quality, which sounds very efficient to me. But this sort of radio bureaucracy is very real. And going through the sorts of hoops to get licensed can take, not just months, but sometimes it can take, a year or two. Additionally, I like to think that, oh, great, I'm giving my patients radioligand therapy. I am not giving my patients radioligand therapy. I am not an authorized user. So, my name is not on any kind of radiopharmaceutical licensing. You have to have, for the A radioactive material license, you have to have an authorized user. That means, federally mandated, training requirements for use of radiation material. Typically, these are going to be your nuclear medicine doctors, your radiation oncologists at your site. Speaking of which, you have to have a very complex, multidisciplinary team. So again, I kind of think of myself as, the top of the food chain as the medical or the clinical oncologist in this setting. But, in this setting, no. I mean, you've got the authorized user within the nuclear medicine department that's going to be doing this. You need the radiopharmaceutical technicians or the nuclear medicine technicians who are actually in the room with a radioactive material, infusing it into patients. You have to think about maintaining their safety for sure. You've got radiation safety officers who have to put together plans for the entire healthcare system to think about, what do we do when that radioactive patient walks into an emergency room and you've got a pregnant nurse who's going to try to take care of it? How do we prevent that? How do we prevent harm in those settings? Nuclear physicists and nuclear pharmacists, and then finally things like scheduling coordinators and nursing. These are inherently settings that you're going to be taking in patients from a variety of systems and clinics. And how do you seamlessly integrate them into your radioligand program is something that you really seriously have to think about. Physical infrastructure is certainly something that I hadn't thought about as a medical oncologist, but if you look at the physical space that's required for these programs, you have to build out a hot lab that's sufficiently big enough to hold these materials. And so you start talking in these areas and like, well, we just don't have anywhere to hold this stuff. And well, can you just build it? Well, it takes investment. You have to have, an appropriate treatment area within the nuclear medicine suite that's got appropriate lead shielding. And, think about where the patient's going to be sitting there and maybe put some additional lead shielding behind that area. Bathrooms are something that comes up a lot in the nuclear medicine suite because, if you have the patient going to the bathroom afterwards, you got to think about decontaminating that entire bathroom. So these are real physical environment things that have to be thought about as you're planning out one of these programs. Supply chain. For those of us who are trying to give Pluvicto commercially in 2023, we know how sensitive the supply chain is for these sorts of medications. This isn't a pill that sits on a shelf in a pharmacy somewhere and has a shelf life of God knows how many years. These are, materials. They come from rare earth metals. So the next time you're listening to the news and, rare earth metals comes up and you're like, well, that doesn't really affect me. Yeah, it does. And it affects your patients. It's got to be made in a nuclear reactor. That's got to be sent directly to that patient. I mean, these things degrade over the course of a couple of days. So very, very sensitive supply chain issues. In 2023, right after Pluvicto was approved, there was significant disruption in the supply chain, which fortunately, took, I don't know, 6 to 12 months to really kind of get through. But it was a really difficult time to get patients into treatment. And something that really reminds us of how sensitive these supply chains are. And then finally, as I was kind of saying, patient navigation is important. How do we get patients not just from, my clinic or my colleagues' patients, but, from across the city, across the state? How do you get them to where they need to go in patient navigation? So what kind of things can we do to improve care for men with castrate-resistant prostate cancer or, men getting radioligand therapy in different settings? Well, one, we just need to optimize treatment upstream of radioligand therapy. We know that far too many men, particularly in this state, are not getting optimal, treatment for hormone-sensitive disease. There's estimates that up to 20 to 60% of patients may not be receiving appropriate doublet therapy in the sensitive disease space. I think you guys heard Dr. Matrena mention earlier that we're going to be doing a little closed-door session talking about, some results of some surveys that we did through the Louisiana Cancer Endowment. So we'll be interested to see what that shows. But definitely think about how we're treating, upstream of the radioligand program. We need to rebuild trust within our community. I think regardless of what system that you're involved with, I think we all got into medicine to try to help patients and making sure that, your institution is really trying its best to engage with the community, go to those, health fairs and really listen to your patients, get out into the community. This is from the Ochsner Community Benefits Guide, one of the PR things that we like to put out, talking about the different health fairs that we did in combination with some pharma partners in trying to get words out at, Zulu. I think we were using different churches around the area, all sorts of stuff. And of all the things that we've done recently, probably the one that I'm most proud of with the institution is really partnering with Xavier, one of our amazing historically Black colleges and universities here in New Orleans, amazing allied health program. And we're opening up a new medical school here in New Orleans in conjunction with Xavier so that hopefully we can start to really train up some folks from New Orleans to take care of people from New Orleans. And I think that will be very important. Oh, and then within that booklet too, I wanted to put this picture up there. I was looking through it yesterday and this picture popped up of Mark Matrana. And I just thought, I wanted to put it in there because he's also just the most trustworthy face in medicine, so. All right, what are some more concrete things that we can do right now though? I think one of the first things that you can do is if you're involved in a radioligand program is really making sure that you're removing any kind of implicit bias into who you're referring into the program. You know, if you're really just saying, I'm just gonna take patients that show up in my clinic or whatever like that, you're gonna miss a whole lot of patients. And so if you think about ways that you can develop real reporting benchmarks, you know, through whatever kind of EHR that you use to make sure that you're seeing where patients are that maybe the ones that you're not seeing. Where are you missing those patients and how can you go out and reach them to get them shuttled into the healthcare center? So Novartis, fortunately, I guess they put out this Pluvicto Epic toolkit for those of us who are unfortunate enough to work with Epic, or fortunate enough. You can utilize this, I kid, I actually really like Epic. But you can utilize this, this worksheet. It kind of works, it walks you through like step by step of how to make a reporting benchmark to identify patients within your health system that could be eligible for the drug. If you're not within Epic, there's other, other third-party vendors that you could potentially use for this. And then also making sure that you're maintaining good communication with your referring partners from outside your institution, making things visible for them to know where they stand in the referral pathway. And then finally, the last thing, and probably the most difficult thing that we need to do is really just expand out more radioligand centers. This map, I'm kind of focused more on how things are looking in the United States, but I think this map really kind of highlights how this is going to be a global issue for supply across the entire world. It looks at per capita use of radioligand therapy for prostate cancer. If you look at it, obviously Australia and Germany have traditionally been at the vanguard of radioligand therapy treatment, so not surprising that they have very good per capita numbers. But in the United States, we're in yellow. That's not great. And I think I previously showed you earlier the map of where the PSMA, PSMA PET sites were. If you did a similar map of where PSMA radioligand treatment centers were, it'd probably look very similar. So we talked a little bit about the barriers of how you can put together a radioligand program, but this was from a review of how we can, what other sorts of barriers might be there in developing radioligand programs. So if you think about this, we talked a little bit about inadequate physical structure. Really making sure that we can invest, particularly in certain healthcare systems, to build out these sorts of programs. That we have the professional capacity to really have those authorized users. What can we do to make sure that we have an adequate supply of nuclear medicine physicians and radiation oncologists? Unclear models of care, this is something that comes up when you refer somebody in to get a radioligand treatment, like who's the quarterback in that situation? Is it the medical oncologist from the outside institution? Is it somebody from within the institution? Is it the, is it the nuclear medicine doctor? Making sure that your center has very clear defined pathways as to who's taking care of these patients and who's responsible for what. Low awareness and understanding, hopefully that's something that we're helping to take care of here today by increasing awareness for these sorts of treatments. And of course, the legislative regulation and reimbursement policies are things that we need to think about. So if we think about, the potential solutions that we could put into this, I kind of think of it as a different type of multidisciplinary team, not the traditional one that we think about, but really thinking about our partners from the governmental side of things, our partners from the industry side of things, and then finally our role here within the healthcare system side of things. So from the governmental side, we really need to make sure that we're finding policies that incentivize, capital investment into radioligand programs, particularly for, maybe smaller, or more rural or, types of settings. We also need to make sure that we're harmonizing, education and training standards kind of across the board so that we all know, what goes into getting this sort of training programs, and getting clear and consistent regulatory frameworks so that we can speed along the regulatory burden involved in opening up these programs. For industry, making sure that we have a diverse supply of these treatments. It's not just industry. I mean, making sure that we have a supply of rare earth metals is going to be important too, so that's on the governmental side of things. And then also continuing to invest in real-world data to see how we're using these drugs and how cost-effective they can be. And then finally, from the healthcare system, making sure that we are telling our colleagues and our patients about these new drugs and increasing awareness throughout the community. making sure that we are training up enough of these nuclear medicine specialists, developing clear patient pathways and standardized clinics that take care of this, and finally sharing best practices. So in summary, radiopharmaceuticals are growing. They're not going away. We're going to see more and more of them. As Dr. Sartor said, we're going to see more and more indications over the next several years. And we already know that significant disparities exist. So if we don't intentionally think about how we expand our programs, we're only going to exacerbate those disparities. And finally, we need to identify those barriers, but really put together that multidisciplinary team of working with our legislators, working with our health administrators, working with our pharma partners, and really making sure that we expand these treatments to all patients who would benefit. With that, I also got some pictures from Mardi Gras this year. That was all the way on the right is what it looks like right before a float rolls. So I threw all of that onto St. Charles Avenue. So thank you guys.
Thank you to our speakers. That was a very thought-provoking session. Dr. Halbert, I want to thank you for bringing up that topic. I will add, cancer statistics are not going to change unless we apply treatments to all people. It's mathematically improbable that we will make any impact unless we apply it to everyone. So thank you for bringing that to attention. So I wanted to open the floor up to any questions that anyone may have right now for any of our speakers. Anyone? All right, well, I'll start. Dr. Sartor, how do you, with the rising use of radioligands, I guess the big million-dollar question is sequencing. So, where do you kind of fit in lutetium in someone who, for example, has a BRCA mutation, and how do you fit that in with the PARP inhibitor before, after, during, or?
Actually, the PARP inhibitors are incredibly active with BRCA1, BRCA2. And I typically give the PARP inhibitor first. We don't have a lot of data with radioligands after PARP inhibitors. It's conceivable that you could put the two together, but there's really not much in the way of data to support that. And would worry potentially about toxicity. I did present the phase 1 data from Shanine Sandhu. I've actually done combination therapy, and those with a somatic BRCA2 mutation had a beautiful response, by the way. But I think in general, for those with a BRCA mutation, probably the PARP inhibitor first is the better way to go.
Okay. Where do you think chemo kind of fits into that picture?
Yeah, really important question. So we have two studies that directly compare chemo with radioligand. One was presented at ESMO in 2025. The other was presented as a therapy trial out of Australia. In both cases, there was no improvement in radioligand therapy relative to either docetaxel or cabazitaxel. And there's still some question in my mind over the tolerability of the docetaxel or cabazitaxel after the lutetium has been given. If you have a patient with a high volume disease, I think it's reasonable to go with the chemotherapy first. If you have a patient with a low volume disease, and there's data to show the low volume disease has less marrow toxicity with the radioligands, I think going with the lower volume disease with radioligands is very reasonable. Please remember that oligometastatic disease can be radiated. You don't need to bring a systemic therapy like a radioligand into that situation, although it can be considered. Anyway, there's a little bit of nuance depending on the age, comorbidities of the patient, depending on chemotherapy, volume of the patient. When I say volume, I mean disease volume of the patient, all fit in. There's one interesting study that I think is relevant. Now, do look at this. Circulating tumor DNA allelic mutant fraction, when it's extremely high, the patients do not do well with lutetium. They do better with a lower mutant allelic fraction. You can measure that on a Gardner or a Caris type assay, circulating tumor DNA. As we go forward, I think we're going to have better biomarkers to help us choose, but right now we're still in evolution.
Okay. And last question to you from me, but where does radium still fit in? Is it relevant anymore?
Yeah, radium's pretty rare in our armamentarium today. I did actually use radium recently in a guy who had PSMA PET positive bone metastatic lesions only, were quite osteoblastic. One of the things that we do have data on is lutetium post-radium retains its activity. And so in this particular case, I did use radium first, and now I'm switching over to lutetium second as he develops some soft tissue disease. Radium also has a pretty good track record for being given before the chemotherapy. So chemotherapy post-radium, pretty good safety record. We have the approval going all the way back to 2013. So we have 12 years, 13 years almost of FDA approval there. So radium does not have much of a role today, but I occasionally still use it. PSMA PET selected bone positive patients only. If they have soft tissue disease, probably no radium.
Great. Any other questions from the audience?
You were mentioning around like the third dose of Pluvicto, watching the PSA decline to say if it's working or not. Are you looking for a certain percentage decrease? And just to know when to stop treatment if it's not effective and then it's not toxicity.
Yeah, great question. And I think we still are struggling a little bit with this. The patient has had a clear PSA increase, and by that I mean 25% above baseline or more. I'm really thinking about other therapies. If the patient is stable, then I'll look at the clinical parameters because we often have pain, appetite, fatigue to be able to assess. It's not just what the scans and PSA shows, it's what the patient shows. Patients who are clinically benefiting, I tend to continue. But if there's substantial increase in PSA at 12 weeks, I'm thinking about other therapies.
I'll follow that up with a question. When do you know to stop? If they have a really good, PSA 90 response, do you repeat a PSMA PET scan to see, after 2 cycles to see if they still have PSMA of the disease?
Yeah, another really good question. And, we struggled a little bit in answering it because of the lack of prospective data. I'll simply say that I've begun to get the PET scans, particularly when we have a good response. What I'm really looking for is oligometastatic disease that I can then convert to an SBRT-treated patient as opposed to necessarily giving more of lutetium right then. With the adaptive therapy, and Louise is the master of this in Australia, Sydney, Australia, if she's got a really good PSA response, she'll just give 2 and stop. And then you can repeat it later. The repeat responses to lutetium in those who responded initially is extremely high, probably in the 80-90% range. So adaptive dosing is something we're still working through, but consider that PET scan to choose the patient to verify the response. I mentioned the paper in Press from Louise, I'm a middle author, Louise is first author, on the PSMA PET total tumor volume being a really important prognostic parameter. Thinking about oligomets, thinking about SBRT, thinking about adaptive therapy, about holding therapy and then re-administering, you have more disease. All of these are in the works, and it's an art form today. I'm not sure that I have the art form perfected, but we're all going to work at it.
So I have a kind of a broad question. Post Pluvicto, you don't have any expiration so you don't have all the metastatic disease, you have disease. Particularly if you have some cytopenias which occurs, what's left? Because that's where I find myself.
Yeah, really good question. It depends on whether or not it's a pre or post taxane situation. Taxanes are clearly active in the post Pluvicto setting. The question is one of tolerability and immunosuppression. One of the trials that I really liked that was published, over 10 years ago now, was using the 2-week schedule of the taxane, the 50 milligrams per meter squared Q2. Author named Kilcum Kulatinen out of a Lancet Oncology 2013 article really showed the 50 milligrams per meter squared Q2 actually beats 75 milligrams Q3 head to head. So overall survival is better in that trial secondary endpoint. A lot of people don't realize that. I use a lot of the 50 milligrams per meter squared Q2 taxane for docetaxel. That gets you into a better position. There's also a French study looking at cabazitaxel Q2 week dosing. Trying to remember, I think it might have been 15 or 16 milligrams per meter squared of cabazitaxel Q2, and that also came out better. So reduce the intensity of your taxane, and you might be able to do a little better. Our clinical trial.
Any other questions?
So with PSMA PET
Yeah, it's a great question. I mean, currently in terms of approvals and insurance approval too, it factors in where currently, at time of diagnosis and biochemical recurrence, but technically all the studies that we're citing and restaging over the last 5+ years has been conventional imaging based. There's now different guidelines, working group guidelines that incorporate PSMA PET in restaging. But the other aspect of that is also, as Dr. Sartor mentioned in his talk, PSMA expression is heterogeneous, and particularly post Pluvicto is PSMA PET the best imaging modality? Probably not. There are other tracers under development, as you mentioned, but conventional imaging, I think, still has a place. But in terms of, what you use for restaging, what you use at initial, what you use post Pluvicto, it's kind of all over the place right now because we don't have any, study data kind of guiding that decision. But
one other brief comment, the liver is problematic. As you go further into the disease, you end up with a higher probability of liver metastasis. And a lot of these are not PSMA PET positive. So conventional imaging, I think, is really important for the liver. And it's not just the CAT scan with contrast and around the contrast to be able to see these lesions. Some of them can be quite subtle. And the other thing we haven't talked about is neuroendocrine differentiation or the double negatives. PSMA PET positive is only one classification disease. There are others. And it's a lot of MD Anderson work on the so-called, what's the term? Aggressive variant, and where the use of platinum plays a role. And problem with that we have to worry about post Pluvicto platelets, because the platelets are vulnerable in that post Pluvicto platinum treated patient. So we're still learning, and we have a lot of unmet needs. I'm a little bit enthusiastic, although not in the visceral disease, on these T-cell engagers. Both the STEAP1 and the KLK2 are both clearly nice in terms of their response rate. Phase 3 trials with the COMPASS trial that you're familiar with, also a new one, pasritamig, coming in with docetaxel. STEAP1 will essentially complete accrual in the next 1 to 2 months for the phase 3 from Amgen, and it's likely to be a positive trial.
Anyone else?
Dr. Starter, when you talk about alpha particles being better suited for smaller cell versus with the larger cell, so when you're looking at these alphas that are in the pipeline, is it fair to say that alphas will be better suited then for earlier disease when that's smaller cell, and then the betas, because they're traveling further and the LET is a little bit different, it would be weird to see?
We're still working through it. When I showed you the Lunar trial, which Jeremy Clay presented out of UCLA and others at UCLA, the ability to treat the microscopic disease with SPRT plus or minus lutetium was actually pretty impressive. It has ratios 0.37. That's like real data, all with PSMA PET as progression criteria, not FDA approvable. As we go forward, I think some of this gets a bit complicated. Actinium actually has 4 alphas. It's not just a single alpha. It might be that some of these single alphas, like the lead-212, could be better in early stage, a little easier on the marrow, a little bit easier on the kidney. We're going to have to run the trials. The alphas are probably better, but they also bring more toxicity and more salivary tox. The 617, which is Pluvicto with actinium on it, it's got some real salivary tox. So xerostomia is something we have to be concerned about. It's an evolving field. And by the way, we're working on it literally every day.
How are you managing xerostomia? I think in the PSMA edition, it was pretty high rates of clinically significant xerostomia for these patients. It bothers them, and that's something that I worry about when we think about moving Pluvicto further and further up.
Yeah, great question. And there a clinical trial about to get underway, prospective trial with Novartis. Today, hydration is the simple one. harder candies, particularly sugar-free candies, you can just kind of suck on and kind of lubricate, lemon drops and stuff like that. But, they can make a difference. Xylitol, I don't know if you've used xylitol at all, comes in either gums or lozenges or even a little pack, can help. And xylitol is actually cheap and easy. There are things like pilocarpine that can actually stimulate, and there's a head and neck literature around xerostomia because of the external beam radiation xerostomia that you can play to. There also, and this is part of a clinical trial, is to look at a device that is actually almost like a retainer from the orthodontist that will slowly leak a salivary substitute. And so it's kind of a constant lubrication. There's a little French company that's working on that, and they're teaming up with Novartis to be able to do a trial to look and see whether or not that really does. There's preliminary data that that's a good way to treat it, but it'd be like a device you have to get fitted. You have to go to like the dentist, or maybe they're trying to do like an AI thing where it'll fit and then come into the palate and then sort of leak this fluid on a continual basis. But it could be a tough problem, and it can really be problematic with the alphas. The actinium is a salivary gland destroyer. By the way, they're also looking at salivary tumors and the use of PSMA targeted therapy at Johns Hopkins. That's, get that salivary uptake. So if you kill salivaries, maybe you can kill salivary tumors too. So positive side to it.
I have a question for Dr. Pillay. A lot of what you mentioned about the Poseidon data, the decision to give ADT and how long is dependent upon risk. But do you find like a lot of these high-risk patients are getting surgery? And should a patient with a Gleason 8 get a radical prostatectomy, theoretically?
Yeah, and that's a topic that every urologist and radiation oncologist will forever debate. But I think it's hard to ignore, Stampede and other data that in the high-risk setting, there is biological outcome differences when we combine, anti-androgen therapy and radiation therapy. All of our, to date, neoadjuvant studies with surgery and anti-androgen therapy, adjuvant studies have not shown, additional benefit to the combination. So just purely out of, we're never going to have a direct comparison trial to go off of, but just in the last 5 years, what has significantly improved outcomes for patients with high-risk localized disease has been the medical oncologist with the systemic therapy addition to radiation therapy. So I think, more and more that needs to be highly considered, and obviously, the patient's active participation in that decision of upfront surgery versus radiation, and quality of life issues and side effect issues, and all of that needs to factor in. But purely based on the numbers, I think we should start questioning more and more, surgery versus upfront radiation in these higher and certainly very high risk N1 positive patients.
One of the downsides of the radiation is it does require that systemic therapy, which a lot of patients are very eager to avoid. And so when you're giving radiation high risk, you pretty much have to give the hormonal therapies with it. And the abiraterone Stampede study, clearly positive study. We are at times committing people to 2 years of therapy with a hormonal agent, and that is not attractive to a lot of men either. So as we think about these non-castrating therapies, and I mentioned the T-cell engagers, several times already, I mentioned the radioligands, of course, many times. I think the radioligands and the T-cell engagers may play a larger role as we go forward. But this is going to take a long time to study properly because the outcomes don't occur within 3 years or 4 years. The best outcomes are 6, 7, and 8 years. So the study is going to have to go on for a long time to be definitive.
Absolutely. I think the next phase of de-escalation studies, as was touched on in all of the talks, are going to be kind of the current, because, as was mentioned, men don't want long-term castration. So all of these new agents, the RIPTAC and radioligands and T-cell engagers, moving up earlier to spare castration.
Great. Okay.
It's a question for each of you. I think Dr. Halbert has talked and honing in on the disparity. I'm just curious with medical oncology and these patients with urology, what do you see in each of your sites as far as when to remediate is appropriate and how y'all are working together to enroll these patients?
Yeah, I mean, I think it's been a long standing issue to look at getting patients into medical oncology, so that at least so that they're getting, a appropriate upstream care from their castrate sensitive disease. I think we all work in different disease states. Fortunately, we have good relationships with our urologists who are very happy to refer into us pretty early. So I think within the Ochsner community, we're pretty good about capturing our patients within. I think where we may be losing some leakage might be, with, patients that may not be followed within a large integrated health system, but, might be still being treated by, a smaller practice or, one of the larger practices out in the community, but that aren't necessarily integrated within medical oncology clinics. So we need to do a better job of integrating with those, with the LUGPAs and with, single practitioner urology groups and making sure that we really seamlessly get better, referral practices in, and so that they also don't feel like they're losing their patients. Because, I think a lot of times they don't like to bring patients in if you feel like they're just, they're going to lose that relationship, and if they're going to, lose that time that they get with their patients. So making sure that, you work with the urologist to, kind of see what level they want to stay involved with.
I think Dr. Matrana's talk at a roundtable at 2:00 kind of addresses this issue: is who ultimately is guiding prostate cancer treatment for patients. Is it the urologist or the medical oncologist? And as Dr. Halbert says, that varies by location a lot. So.
I mean, that's kind of part of what we were saying earlier with one of the barriers of expansion of radioligand therapy is this, unclear models of care. It is. It's like, who is the quarterback for these patients whenever, they might have been followed with their urologist for 10 years and then they've been seeing you for 5 years and now they're getting nuclear medicine, it's getting involved, and, really making sure that each institution comes up with something that works for them and their patients, but just so that we all know who's doing what.
Short answer is all the, everybody has a role to play. There are things that urology does that I'll never do, things that radiation oncology does that I'll never do. It does take a village in order to be able to do it optimally. The village is most functional when people are all communicating with one another, and that's the optimal setup, is to make sure the communication across specialties is clean, referrals happen rapidly or even in real time. And that's a huge advantage to the patient. If you're just isolated and have only one specialty, I hate to say it, you're probably not getting the best of care throughout the continuum of prostate cancer. Sure, for surgery, it's going to be urology. For radiation, you must have. But at the same time, integrated therapies, including combinations that we use every day for the hormonal therapies, that's probably best an integrated approach.
Yeah, and I think in that space too, increasing roles for non-physician members of the team, patient navigators, coordinators, that can help sort of quarterback that overwhelming coordination aspect, for the patient, and understanding, who's part of your care team, who's responsible for what, and who do you need to see when.
All right. Any other questions? All right. Well, thank you all for joining us today for this wonderful session. Thank you to our presenters, and enjoy the rest of the conference.